Hello, everybody. Welcome to the next lecture from AAT Learning Hub on a very interesting topic dealing with understanding the cardiac output. Let's take a look at what all we are going to deal with in this lecture. We'll begin with what is cardiac output, how to calculate or measure cardiac output, what are the various factors affecting cardiac output, what happens to cardiac output during exercise, and we'll finish with some clinical conditions having high and low cardiac output states. So, cardiac output essentially is the amount of blood pumped by the heart in a minute. It can be calculated by multiplying heart rate with stroke volume. Let's first look at the units of expression of these two parameters. Heart rate is expressed in beats per minute and stroke volume in milliliters per beat. If you strike off the two beats, what remains is milliliters per minute. The normal heart rate is anywhere between 60 to 100 beats per minute, depending on one's age, gender, health, and lifestyle. As a convention, we all know that heart rate is usually taken as 72 beats per minute. Stroke volume is the volume of blood ejected by the ventricles with each beat or in one cardiac cycle. It must be noted that the ventricles do not empty all of their blood with every beat, as you must have understood from my previous lecture on cardiac cycle. If not, I strongly recommend you to watch my previous lectures to have a better understanding. Here you see the picture of a heart in diastole on the left. You can see that the ventricles are relaxed and expanded to allow the flow of blood for filling. On the right side, you can see a contracting heart, meaning the ventricles are in systole, pumping the blood into the great vessels. At the end of diastole, the volume of blood that is filled in the ventricle is called the end diastolic volume. The volume of blood in the ventricles at the end of systole after rejection is called the end systolic volume. The end diastolic volume, as a rough estimate, is around 120 ml, and the end systolic volume is roughly around 50 ml. So, subtracting the end systolic volume from the end diastolic volume, we can arrive at the stroke volume. That is the volume that remains in the ventricle after filling minus the volume that remains in the ventricle after ejecting will give the volume that was ejected out. That is 120 minus 50 ml is 70 ml as a rough estimate. So, plugging these values into our cardiac output equation, 72 multiplied by 70 equates 5040 ml, and to round it off, 5 liters per minute. For an individual at a given time, cardiac output can be calculated non-invasively by echocardiography or cardiac MRI, or invasively through right heart catheterization using the fixed principle or the thermodilution system. Let's now move on to the multitude of factors affecting the cardiac output. The body's demand for oxygen varies with activities and is altered by modulating both heart rate and stroke volume. The changes in cardiac output from baseline are directly proportionate to changes in total body oxygen needs. During physiologic stress, as in exercise, cardiac output increases to ensure adequate tissue perfusion. As a result, the regulation of cardiac output is subject to a complex mechanism involving the autonomic nervous system, the endocrine, and paracrine signaling pathways. Let's dig deeper into each of these parameters and understand the various factors affecting them. Numerous factors affect the heart rate and in turn affect the cardiac output. The stroke volume can be influenced by three main parameters: the preload, the contractility, and the afterload. Let's look into each of these factors affecting the heart rate. First and foremost is the sympathetic nervous system, which releases chemicals like epinephrine and norepinephrine that act on beta 1 adrenergic receptors and cause an increase in the heart rate, known as positive chronotropic action. Next is the parasympathetic nervous system, which, when stimulated, secretes acetylcholine, the chief neurotransmitter of the parasympathetic nervous system, that activates the muscarinic type 2 receptors, going back to our physiology, causing the cell to slow down the action potentials, thus decreasing SA node discharge rate and AV node conduction velocity, and causes a decrease in the heart rate, or in other words, exerts a negative chronotropic effect. Thyroid hormones T3 and T4 are powerful regulators of heart rate. They increase the basal metabolic rate and cause a positive chronotropic effect on the heart. They act via the nuclear receptors and ion channels in cardiomyocytes, resulting in an increase in heart rate. Body temperature is an independent determinant of heart rate. For every degree of raise in body's internal temperature, the heart rate increases by about 10 beats per minute approximately. In a normal heart, there is a balance between calcium and potassium ion levels in both the outer and inner walls of the heart. That balance keeps the electric energy flowing correctly through the heart and allows the heart muscle to expand and contract as the heart beats. An imbalance in these ions can lead to alterations in heart rate. Increased levels of calcium ions or hypercalcemia can cause an increase in the heart rate. In contrast to calcium ions, potassium ions have the opposite effect, that is, hyperkalemia causes a decrease in the heart rate, and higher levels can even cause the heart to arrest. What about hydrogen ions or your pH? An increase in hydrogen ions in the extracellular fluid causing low pH or acidosis activates the peripheral chemoreceptors, causing tachycardia initially. Drugs play a major role in regulating heart rate. Epinephrine, norepinephrine, dopamine, dobutamine, atropine are drugs that increase the heart rate, whereas drugs such as beta blockers and calcium channel blockers decrease the heart rate. What about age? Fetus and infants have a higher heart rate, around 120 to 140 beats per minute. Adults have an interesting resting heart rate of 60 to 80 beats per minute. And interestingly, females have a faster heart rate than males. Typically, on an average, it's 72 to 80 beats per minute for females and 64 to 72 beats per minute for males. A word about endurance trainers. Athletes tend to have a lower heart rate than non athletes. This is because they run or train excessively, putting their hearts to a lot of work, that the myocardium becomes really strong and develops a pretty high stroke volume. Hence, over a period of time, the heart doesn't need to beat as fast to maintain adequate cardiac output, and that's why they tend to have a lower heart rate. Other physiological factors that can increase the heart rate include anxiety, emotional stress, pain, pregnancy, etc. So that's about heart rate. Moving on to factors affecting the stroke volume. As I said, stroke volume depends on three parameters: preload, contractility, and the afterload. Let's take a closer look at what is preload. It is the load imposed on a resting cardiac muscle that stretches it to a new length to allow filling of blood. In other words, preload is the extent to which the ventricular wall stretches at the end of diastole. One can imagine this being equivalent to a balloon getting inflated and increasing in size to allow the air in. As we have no means of measuring the length of stretch of a cardiac muscle fiber, the preload is equated to end diastolic pressure. Let's look into the factors affecting each of these parameters. Changes in preload directly affect stroke volume, influencing cardiac output and heart's overall function. Preload is largely regulated by venous return, which in turn depends on the systemic vascular resistance and venous tone. Total blood volume, the filling time and atrial contraction, heart rate, resistance from valves, and atrial and ventricular compliance may also significantly contribute to regulating cardiac preload. As preload increases, stroke volume increases proportionately. Contractility refers to the force of contraction of the heart muscle, which contributes to stroke volume. According to the Frank-Starling law, going back to our physiology again, the force of contraction is directly proportional to the initial length of the muscle fiber. This means that the greater the stretch of the ventricular muscle, the more powerful the contraction is, which in turn increases the stroke volume. Therefore, by increasing preload, contractility is increased. Sympathetic activity is the most important and direct determinant of contractility. Hormones, norepinephrine, epinephrine, thyroid hormones, and glucagon demonstrate positive inotropic effects. Drugs such as digitalis lowers the heart rate and increases the strength of contraction. As with preload, when contractility increases, stroke volume too increases. Afterload is the total load that must be moved by a muscle when it contracts. In other words, it is the pressure or resistance that the ventricle must overcome to eject blood. Systemic vascular resistance and pulmonary vascular resistance are afterload indicators. Afterload is increased due to an increase in aortic pressure, systemic vascular resistance, or in conditions such as aortic stenosis. The ventricle responds to chronic elevations in afterload by concentric hypertrophy, causing increased wall thickness and decreased chamber diameter. Because of which, in contrast to preload and contractility, an increase in afterload causes a decrease in stroke volume. Next, let's discuss what happens to cardiac output during exercise. The resting cardiac output, as we calculated earlier, is around 5 liters per minute. To cater to the increased oxygen demand during exercise, cardiac output increases to about 4 to 6 fold and reach anywhere around 20 to 30 liters per minute. This is due to the initial increase in both heart rate and stroke volume to about 150 beats per minute and around 130 ml per beat respectively to reach approximately 20 to 30 liters per minute. With increasing workload, the heart rate increases, but stroke volume decreases because of diminishing diastolic filling time, that is the ventricular relaxation time. As a result, the cardiac output plateaus or levels off at a near maximal exercise. Moving on to the last segment of this lecture, let's review some clinical conditions that can lead to low cardiac output. That includes coronary artery disease, congenital heart disease, valvular heart disease, hypertension, congestive heart failure, shock, arrhythmias, genetic diseases like cardiac amyloidosis or cardiomyopathy, pericardial effusion, massive pulmonary embolism, cardiac tamponade, or even post cardiopulmonary bypass. Clinical conditions that can lead to high cardiac output include sepsis, anemia, pregnancy, AV fistula, thyrotoxicosis, lung disease, cirrhotic liver disease, myeloproliferative diseases, carcinoid syndrome, beriberi, and sometimes morbid obesity and chronic hypercapnia. With that, we come to the end of this lecture. I hope you now have a clear picture of how the heart maintains the body's overall function through its cardiac output and rhythmic beats, similar to the notes of a musical rhythm. You might have heard many new terms today because cardiovascular physiology is so deeply connected with the nervous system, endocrine system, and the innumerable activation pathways. So please do revisit and revise these terms to gain a perfect understanding of our body's fascinating physiology. If you found this lecture helpful, please feel free to share it with your friends. Also, don't forget to like and subscribe to our channel. See you next time with another engaging topic. Until then, stay focused and stay curious. Bye bye.